to our roundtable on healthcare. Today we have with us Dr. Lucy Osborne, Professor of Pediatrics at the University of Utah, Norm Weitzman, Professor of Economics at the University of Utah, and Bob Huffner, Professor of Political Science at the University of Utah. First, I'd like to welcome you all and thank you for coming. Today we're going to be talking about healthcare in the United States. And the first thing we'd like to consider is, what do we want from a healthcare system as physicians, consumers, and communities?
As a physician, I would like to be able to work in a healthcare system that is able to provide adequate care to all those patients that I am responsible for taking care of at a competitive price that patients can afford, so it's available and there. With the proviso of remembering that health is what the outcome is, to keep people really healthy, and that much of what we can do in the healthcare system does not necessarily determine health.
Okay.
And that's pretty close to what I'd say as a consumer. I'd be especially concerned with a system that treated me as an individual, that respected me as an individual, and one that was easy for me to understand, and one that I could trust. And in all of that, gave me reasonable assurance that I was getting the best care, and particularly to help me stay well.
From a community standpoint, I think that there are several concerns with healthcare delivery and finance, but perhaps the delivery of good care and at the least cost would be, from the standpoint of an economic system, very important. But also the acknowledgement, as Lucy pointed out, that there are other determinants of health other than medical care per se, and that we have to be concerned about allocating resources among all of the competing goals, because
what are these other determinants of health?
Well, education, for example, for the maintenance of the environment, because of and this includes the workplace and the home, and that if we devote more money to healthcare rather than to these other competing resources, the return we get in health from medical care might not even be as high as if we devoted those resources elsewhere.
That's a good point. If you look at prevention and what is actually preventable to keep you healthy, about 60% of preventable problems are related to behaviors. So the environment in which people are in is tremendously important. Whether or not you wear your seatbelt makes very big difference in the costs of care and the cost of delivering care.
More difference, would you say, than the quality of the care that I might receive from my physician or in the hospital?
In almost every case, I would say that the social-political aspects of the society in which you live are far bigger determinants than the actual care that you can
and our individual lifestyle that's related to that.
Exactly.
Okay, well, now getting back to the industry as itself, often we think of an industry as it can be regulated by market forces. Just allow competition and healthcare will lead to a harmonious outcome. Can you explain to us, Norm, how competition in an industry is supposed to work?
Sure. Ideally, in the market for typical commodities such as hot dogs and hamburgers, we'd expect the market to do a good job in some respects, because people use their resources to go out and purchase them. They're well informed. They're assumed to be perfectly informed, in fact, and they're acting to maximize their satisfaction in the market. And producers on the other side, competing against each other, are trying to offer these goods at the lowest cost. And that interaction and that competition is going to tend to drive out producers that are not doing a good job or efficient job, and to sustain the ones that are doing a good job, so that the consumers, in a sense, get the biggest bang for their buck automatically through the operation of those market forces.
So what are the concerns about competition in the delivery of health care?
Well, if I could just start off, and Bob and Lucy might have some other things to add, is that we obviously face some information problems here. And for example, when we go to a physician, we in some sense are hiring the expertise of the physician, because we're not perfectly informed about our health. It's a very complicated system, our biology and so on. So we're asking for the expertise of a physician, and they're acting as our agent. And in some sense, we'd like the physician to act as if they were us, in our shoes, and for demand to reflect all the utilities and the satisfactions that we were talking about before with respect to the hamburgers. So if the physician does not act in the interest, then there's some discontinuity and some disruption in some sense of a perfectly efficient operation. On another level, there's what's called adverse selection in the market, where insurance itself tends to charge an average price for insurance premiums rather than an experience-rated price, which would reflect all of your risks, because they don't have all the information about whether you smoke or wear seatbelts and so on and so forth. So they charge an average price. And what the average price can do is tend to drive out the very good risks and leave the bad risks behind, and tend to drive up the price for insurance, so we don't get the optimal amount of insurance as we would in a competitive market. Those are two examples.
And I would add that one of the problems with looking at healthcare in a competitive model is that it's a very complex system. You have the information problem that Norm was talking about, but you also have it segmented in a way that does not make sense. With insurance companies, you have separated the payment from the service from the actual service itself. So if I go in to the supermarket and I buy an Oscar Mayer hot dog and I don't like it, and I don't like the price, I just choose a different one and I pay for it. I can even make the choice. Do I want the cheaper hot dog and not like it quite so much, or do I want the more expensive one? And that is not generally what happens in the healthcare system. I am employed. That's usually where you get your health insurance. So it's my employer who is buying the insurance for me, so that my choices are somewhat limited. And what is the employer interested in? Again, they're probably interested in getting things for the lowest price, and they're buying into a system which the complexities thereafter are tremendous.
You know, I think the model of a market is very useful in terms of the kinds of questions it raises about healthcare. Not that a market's always going to be good, nor that it'll always be bad, but it just helps us to understand some of the questions. For example, on what Dr. Osborne was just now talking about, my own feeling as a consumer is that the medical care that we're receiving has substantially increased. Hasn't increased our lifetime very much in the last 100 years. But to me, who is, as a person who's interested in knowing what's going on and having some choice and being respected as an individual, in some ways it's made some great progress. That I now, when I go to my physician, have a physician who tries to extend my understanding, and not only is telling me what he knows about my condition, but is also sharing with me what he doesn't know. and that's very helpful to me, just to understand not just what he can share with me, but where we're both uncertain about what might come from my condition or from the kinds of treatments that are being provided.
You brought up an interesting point, though, about we're consuming more health care than before. And could you explain to me, do we actually consume more? Why are we going to the doctors more, but we don't seem to be much more healthy because of it? Is that true, or?
It is true that and it's one of the, when you talk about managed care, it's one of the ways of controlling the amount of consumption of care. That's why you have this primary care and gatekeeper and whatnot, so that you can't get from me to the specialist without going through me as the primary care physician, trying to get some, or nurse practitioner, whatever, trying to get some control over people's unlimited use of health services.
Why do they have an unlimited use of health services? And why should I be going to the doctors more and more often than, say, my parents?
Well, actually, the number of office visits to the physician in the United States is actually lower than in most countries. And it probably isn't all that much different
from historically.
And even historically, I don't think that the numbers of visits, it's what's done in the visit and what's done and typically what's been done in the hospital, the technology and the amount that's available to be done, the intensity of care that's increased so much.
Is that because hospitals and doctors are worried about getting sued if they don't do all these things, or is it because the consumers want this and demand it?
Well, remarkably, defensive medicine is actually, from most studies, which is what the fear would be characterized as, tends to consume a very small part of, of overall medical care. But if you look at the growth of medical care provision in the United States and in other countries as well, we're growing it before the most recent years at a rate higher than the rate of inflation because of so much more that can be done. And part of this is because of the rewards for growth, which are implicit in what was basically a fee-for-service system. I think that that's partly it. Partly
the rewards in what sense? Who gets these rewards?
That if, say that a hospital doesn't have the latest in terms of a magnetic resonance imaging system or a CAT scan system, you're going to lose patients to another hospital because of the threat, even if that now you need to sustain the utilization of that system for it to pay itself. And so the existence of the technology tends to beget utilization in some respects. And the diagnostics that can be done, all of the procedures that can be done have just ballooned, partly because of the payment system, but also because of the faith that we have in medicine, I guess, as it's grown since the huge breakthroughs in partly pharmaceutical technologies.
You know, Dr. Osborne was saying before we started, as we were talking, that probably not many physicians are deliberately providing services that aren't needed, and I think that's true. But the important part of what's going on is we're not very sure, I mean, as patients and as physicians, about just what will be the appropriate treatment or what kinds of tests ought to be made. There's a lot of room in that. And that's where the market comes back again. And what Norm was just saying, if you've got a market where the primary incentive for the market is to feed out more services, and you're not really sure what kind of service is needed, it's not a matter that people are deliberately trying to do too much, but it is a matter that they're being encouraged not to hold back.
And when you separate the payment system from that, so that I, as the person going for the service, don't have to pay for the full service, then that incentive is not there.
Which means we've also lost another important component of a market.
Of a marketplace.
Is that I don't pay, so
you don't pay the full costs.
Okay.
You know, and it has been shown that co-pays and other things do make a difference. But on the physician side of this, about talking about increasing service delivery, you know, we are trained to try to help our patients. You want the best outcome for your patients. And I can just, in my own medical career, I've been in practice for almost 25 years now, and have seen tremendous things that we can do. I mean, from antibiotics that allow us to make diseases actually treatable, which were untreatable before, to new immunizations. I mean, when I first started in practice, the total cost of immunizing a child was about $10. Now it's probably about $500 because we can immunize you now against all these other diseases and prevent these diseases. The other thing that is going to go into this continuing increase in the cost of care or consumption of care is the aging of the population. If you look at where do people consume the most care, it's in the first year of life and after starting about age 60. And we now have all these interventions that we can do for the very small babies, so we have been using much more care in that first year, and I'm sure that if you were to compare costs previously, I mean, you're the people who can tell me about this, but that those costs are going up tremendously, and the costs of care for the aging population will go up. And so the need for the actual delivery of care and what's done is not going to decrease.
I want to dispel just one impression that might be created in that we're not getting any return from these increasing expenditures. The newest studies show that actually after age 65 in the United States, we actually do as well, if not better, than most of the other Western industrialized societies. A fundamental question is, are we getting the return is that extra amount of life, first of all, quality life years, and second of all, is the amount of expenditure justified based upon the level of return that we get? It's not a matter of whether the physician is providing additional care that does harm or doesn't do any good. It might well do some good. The question is, would those resources do better in somewhere else?
And Norm, the way you explained that raises another important question about our system. That is, you said that once we reach the age 65 in this country, that then the health care we receive is as good as any place in the world in terms of what it does to extend our life. That's if we reach the age of 65.
Oh, that's
well,
right.
what's that saying? That's saying that before 65, a large part of the determinant of our healthiness in this country has to do with our social economic status. And that part of the issue about our healthcare system is a question of access. Not just in terms of do most people have access, but how about the poor? How about some of the minorities and so forth?
Tell me something about access to the U.S. healthcare system. Which groups tend to be excluded or have difficulty obtaining good health care?
If you need it.
Yes.
If you're sick, you have a hard time, and if you're poor.
And some in the rural areas.
In rural areas.
And then minorities, especially those that do not speak English, or have different kinds of cultures where the medicine, the medical procedures for those cultures don't match ours.
We're formally, I think, at about 85% of the population covered under some health insurance, with up to 20% that loses coverage at a point during a year. A larger portion of that is growing we have two public programs that are very important. One is the Medicare program, which covers the over 65 population as well as the disabled. And we have the Medicaid program, both of which were actually passed and expanded around 1965, which covers the poor sections, and that's a federal-state program. So we have these two programs, the Medicaid program in particular, growing to cover a larger portion of those who are uninsured in the United States, and then the rest covered through employer-sponsored, for the most part, health care.
Now,
Can I interrupt for just a minute? We've talked a little bit about access, but I want to go back to a comment that Norm made. And the other part of the system that is important in judging it, and it comes in the economics, is the quality. And when you were talking about whether or not is the care after 65 best or what it is, that is one of our problems, is actually measuring the quality and knowing what the product is that you're actually getting. So that just as important as increase in lifespan is whether or not treatments actually give you a better functioning. That's what's going to be important to your employers who want to keep a healthy workforce. And back to the information systems, a lot of this is really not well known, that as we go towards perhaps a different organization of healthcare, such as managed care, there are certain parts of the system that will just simply have to be improved in order to be able to make the judgments to make it behave more like a regular market.
Which gets back to Norm's very first point, talking about the market. One of the places where the present system fails is we don't have good information. Now, in medical care, we'll never have full information. It's just too complicated and technical. But every time we talk about a change, a key question we ought to be asking is, well, how does information relate to this change? And how are we going to be able to understand our choices? And how's information going to help provide the incentives to keep the program honest and providing good care?
So, okay, just to give you a real specific example, if I am employed and I have trouble with my back, and we can't even tell you if I will get back to work faster and more cheaply by giving me physical therapy versus going and having my back surgery done versus simply not doing anything at all. That our information regarding many of those things, we can tell you if I do the operation on you, how long it takes you to get back to work, and I can tell you if Dr. X does it, he'll do it faster than Dr. Y, but we don't have comparisons across different types of interventions, different types of products.
That's right. You know, it's interesting. The studies show a great deal of area-wide variation within state, across the country, on various procedures. It's very interesting.
Incredible.
And none of which would be not nearly the amount of which would be justified based upon just differences in age and the demographic profile of populations. So these are differences in the delivery style and in other factors related to healthcare delivery. And it's not a matter it's a matter really of this information question as to what is going to. I think that we've gone through a golden age to some extent of care, and medical care has got the sense of being a panacea, and perhaps the system is reassessing itself now to try to make judgments as to whether the golden age is one that sort of is over in some respects.
Or can we make it more
Can
golden?
we make it more golden?
Yeah,
Sure.
can we find out if what we're doing
The
we
golden
can do
years
better?
are golden.
Well, this is a question I want to get at then. When we've heard a lot about healthcare reform, but I'm not exactly clear, what are the real problems with the present system we have? What's not working about it? And when you said there's informational problems, give me an example of why that would create a problem, I mean, in our present system. So tell me what's wrong before we talk about how people have said how we can fix it. I want to know exactly what is wrong.
You can look at sort of the three-cornered or the three-legged chair of cost, quality, and access as sort of where things are wrong now. And I'm sure that we could elaborate on each. We have a system that's the costs widely perceived have been running awry, at least until recently, where access is 85% and maybe even less at some point.
And who bears these costs?
In terms of...
Yeah, why is it a problem that costs go up in medical care?
Well, it's not necessarily a problem if people would be willing to pay what they receive, but there's getting to be the perception.
Just look at how much it is. When it's 15% of the gross domestic product, that's more than all we spend in this country on defense. It's more than all we spend on education, private and public. It's more than all of those together. And if we're concerned about family income, if we're concerned about taxes and so forth, at this point, we have to be concerned about healthcare costs.
And actually, if I could take that to another plane, which is as these costs are being diverted, for example, from your education system to your medical care system or your healthcare system, you may actually be worsening health because, as we started off with, the major determinants of health aren't necessarily part of the healthcare delivery system. It's socioeconomic class, whether or not people are educated, whether or not they can get jobs, whether or not they're productive employees.
And just while we're on that, while we're still on this detour, but it fits so nicely, when we start talking about reforms, we say, well, it doesn't matter how we pay for it because ultimately we pay for it as consumers. But in fact, it does matter what the mechanism is by which we pay for it. For example, if we made a shift that had most of it being paid for by the federal government, it would be competing primarily with Social Security. So it's probably going to be taking money out of the hands of the elderly. If we finance it largely at the state level, it's going to be competing primarily with expenditures for education. So it would be primarily at the cost of education.
Whereas, like robbing Peter to pay Paul.
The question is which Peter we're robbing.
And employer-based insurance makes your goods and services less competitive.
That's right, it's
in the
take-home
market.
pay.
So so the costs really do make a difference.
And the
how they're
reform makes a
organized,
difference.
and the reform does.
Okay, and quality?
Yeah.
What's happened? I'll let you get onto this, but I want to get the three. Cost, quality, what's happening?
The quality question is of particular interest because people want to know if they choose a lesser cost option, if they're still going to get optimal care. And there are lesser cost options that are out there on the market in terms of HMO, for a health maintenance organization, for example, where you get all of your care typically at a lower cost than under your fee-for-service medicine. And the question many people have on their mind is the doctor going to send them to the specialist if they need to go to the specialist? Are they going to get the specialty care that they require? Because the bias in the HMO system is to provide perhaps less care. So these questions of quality are resurfacing again and again.
There's a lot of question of quality in the present system in terms of whether or not we're getting too much care in some cases, which can be every bit as damaging to me as too little care.
And then I will make the pitch for the primary care part of it, and that is that I think that that oftentimes we look at quality more on the tertiary care service, on the high end of services.
What do you mean by tertiary care?
Oh, when you have to go in for surgery or some complex kind of illness. And really, the basic care, what's really going to help us is if our basic care is of the highest quality. Such as just delivery of regular services, so that when you have a simple illness, immunizations, preventive health care, just your very basic day-to-day care, the quality of that is really, really important. And it's not something that we've emphasized in our education system. It's not something that the insurance companies emphasize.
And part of the quality of that primary care is being able to offer really good advice about when you need other care.
And delivering the care.
Okay.
So, and the quality, I would say in the end, is getting the right service to the right person, to the right provider in a timely fashion.
Okay, and we talked about access, problems with access. So now I want to go back to these three areas of problems in the healthcare system: cost, quality, and access. So cost, why is it going up, and what solutions do we have to try to control it?
We ought to clarify that for the first time, the last...
Or is it going up? Yeah.
that actually, and I don't know if 2 years is a trend, but it does seem as though there has been a rope that's constrain or restraining the cost increases, so that the healthcare inflation has been reduced in the last few years.
Why were they going up before that?
Well, I think that that part of it is the kind of rewards that we were talking about before inherent in the system for doing more. Under a retrospective payment system, if you go into a hospital, the longer you stay, the more things that are done, the more lucrative it is to the hospital to do more things. And so under a prospective payment system where you pay per diagnosis up front, you come in with a pneumonia and they give a certain amount for the bundle of services, the hospital actually has the incentive.
Okay, so they want me to end, so thank you for watching today, and thank you again for coming.
Thanks.